Welcome to the Australian Dental Council Explainer podcast. Before we really dive in today, we just need to state right up front that this content is purely educational and not a commercial endorsement.
Right, yeah. We always want to keep that completely clear before we get into the clinical weeds.
Exactly. So, our mission today is tailored specifically for you, the ADC candidate, the dental student, or maybe the oral health therapist listening right now. We want to sharpen your clinical reasoning for the OSCE exam.
And to do that, we are pulling a really classic high-yield scenario straight from a staple text, Odell's clinical problem solving in dentistry.
We're doing a deep dive specifically into Case 8, which focuses on painful trismus.
It is such a textbook presentation, but, it's one that routinely trips up candidates on the clinic floor if they don't follow a highly systematic approach.
Oh, totally, because the urge is to just see a limited opening, label it as trismus, and move on.
Which is a huge mistake.
Right, so we are stopping right here. Picture this scenario. You have a 27-year-old woman sitting in your dental chair. She's a former gymnast, and she was previously diagnosed with generalized joint hypermobility.
Keep that hypermobility in the back of your mind. It's a massive clue.
Definitely. So for years, she has had these sporadic, completely painless clicks in her right jaw joint. She didn't think much of it. But 3 days ago, while chewing on a really tough, chewy piece of meat, she felt this sudden, sharp pain right in front of her right ear.
And now she is in absolute agony.
Yeah, she cannot open her mouth past 23 millimeters. You do your exam, and you notice a right-sided deviation when she tries to open.
Okay, and what about the lateral movements?
So you measure her lateral excursions. She can move her jaw 8 millimeters to the right, but only 1 measly millimeter to the left.
Wow. I mean, that 1 millimeter measurement is the thread that really unravels this entire clinical mystery.
It really is. So here is our challenge to you listening right now. Before we break this down, think about your own clinical knowledge. What is your initial differential diagnosis?
Based on the chewy meat, the 23 millimeter opening, the hypermobility, and that 1 millimeter left excursion.
We want you to drop your thoughts in the pinned comment below right now. Seriously. Pause and commit to a diagnosis before we reveal the mechanics.
Committing to a theory is so important because it forces you to actually defend it. And to defend any diagnosis in this scenario, well, we first have to agree on the terminology.
Yeah, let's unpack this. Because the way we use the word trismus clinically often, it kind of blurs the lines of what it actually means.
It really does, because true trismus, the historically accurate definition, is specifically a reduced mouth opening caused by a spasm of the muscles of mastication.
Right, like a motor disturbance of the trigeminal nerve. It implies a muscular, usually temporary, extra-articular issue.
Exactly. But in modern clinical reality, we just use it as a catch-all term. We use it loosely for almost all causes of limited opening, whether it's muscle, joint, or an acute infection.
Which means writing trismus on your patient's chart is just describing a symptom. It's not a diagnosis at all. You have to figure out the underlying mechanism.
Right. You have to ask, is the problem outside the joint or inside the joint?
And Odell's text has this brilliant analogy to help visualize extra-articular trismus. I always use this mental image during OSCEs.
It's a string analogy.
Yeah. Imagine your patient has a piece of string tied tightly between the tip of their nose and the point of their chin.
It's such a highly effective way to isolate vertical restriction.
Because that string physically prevents the jaw from dropping down. But if the problem is strictly extra-articular, say, a severe spasm in the masseter muscle, the temporomandibular joint itself is still perfectly healthy.
Right. The actual hinge and sliding mechanism is untouched.
Exactly. The condyles can still translate forward. So even with that imaginary string pulled tight vertically, the patient could still slide their jaw left, right, and forward.
Their lateral and protrusive movements are completely unrestricted by the joint anatomy. So let's apply that directly to our 27-year-old gymnast.
Her clinical picture totally contradicts that extra-articular model.
Right. She doesn't just have a vertical restriction locking her at 23 millimeters. She has a severe restriction in her left lateral excursion.
Just 1 millimeter of movement. Plus, her jaw deviates to the right when she tries to open. Let me trace that mechanical pathway to show why that matters so much.
Go for it.
If I want to move my jaw to the left, my right condyle has to slide forward and down the articular eminence.
It has to physically translate.
Yeah. And if our patient only has 1 millimeter of leftward movement, that means her right condyle is hitting a literal wall. It just cannot move forward.
And to understand why it's hitting a wall, we have to isolate the two distinct compartments of the TMJ. When you first start to open your mouth, like the first 20 millimeters, the condyle is just rotating in the lower joint space.
It acts like a simple hinge. And our patient can open to 23 millimeters, right?
Which tells us that the lower joint space, that rotational hinge mechanism, is functioning perfectly fine.
The breakdown is happening in the second phase of movement. Because to open wide past those initial 20 millimeters, or to move side to side, the condyle has to slide forward.
Right. That gliding movement is translation, and it happens exclusively in the upper joint space.
So because forward translation of the right condyle is absolutely required to move the jaw left, a severe limitation there points directly to an intra-articular cause on the right side.
Something inside the upper joint space capsule is physically blocking that forward glide.
And this is the critical diagnostic branch in the OSCE tree. Just by measuring the lateral excursions, we have completely ruled out extra-articular issues.
It's not just a muscle spasm pulling the string tight?
No, and it's not an extra-articular infection either. The problem is a physical structure inside the right joint.
So, establishing the location is the first step. Now we must narrow down the specific pathology without jumping to conclusions.
How do we do that systematically?
Well, the text introduces the research diagnostic criteria, the RDC system, for categorizing TMJ pain. It groups common culprits into three main buckets.
Okay, what are they?
Muscle spasm, which is myofascial pain, osteoarthrosis, which is degenerative joint disease, and internal derangement.
Well, we've already discarded the myofascial pain category using that lateral excursion test. But I want to push back on the remaining two.
Okay, let's hear it.
Because the patient's history throws us a couple of curveballs. Could this just be a traumatic injury from chewing the tough meat, like a traumatic synovitis?
The chewy meat is undeniably the precipitating event, yeah. But traumatic synovitis doesn't align with the specific mechanical restrictions we see.
Why not?
Because traumatic synovitis is a generalized inflammation of the synovial lining of the joint capsule.
So it'd be like a swollen, angry balloon inside the joint.
Essentially, yes. And because that swelling is generalized, it typically causes pain across all joint movements.
Oh, I see. The patient would just guard against any movement that compresses that inflamed tissue.
Exactly. You wouldn't typically see this selective, severe mechanical impairment where one specific translational movement is totally blocked down to 1 millimeter, while rotation is perfectly smooth up to 23 millimeters.
Right. Inflammation doesn't create a hard mechanical stop in just one direction.
Exactly that.
Okay, I follow the logic there. A hard stop requires a physical obstacle, not just fluid. But what about osteoarthrosis?
It's definitely in the RDC framework.
And she's a former gymnast with generalized joint hypermobility. Her joints are inherently unstable. Couldn't that mean she's experiencing early onset arthritis and the cartilage has just worn away?
It is an excellent differential to consider for a hypermobile patient. However, we have to look at the evidence in the text of how cartilage actually degrades.
Okay.
Osteoarthrosis involves the failure of cartilage repair. On a microscopic level, you see a loss of proteoglycans within the cartilage matrix.
So I always think of proteoglycans like microscopic water-retaining sponges.
That's a great way to picture it.
They pull water into the cartilage, giving it that plump, shock-absorbing cushion. So when those sponges are lost, the cartilage dries out and loses its structural integrity.
And that loss of integrity leads to fibrillation, which is the physical fraying and splitting of the articular cartilage.
The smooth gliding surface becomes rough and pitted.
Right. And eventually the cartilage breaks down entirely, leading to bone rubbing on bone.
And when bone rubs on bone, we get the hallmark clinical sign of osteoarthrosis crepitus.
That grating, crunching, gravel-like noise.
But our patient doesn't present with crepitus. Her history notes a clean click for years, not a crunch.
Furthermore, osteoarthrosis typically presents with radiographic changes, like osteophyte formation, which takes years to develop and causes a gradual decrease in function.
While our patient had a sudden, rapid onset locking event over a matter of seconds.
Right. Despite her hypermobility, there are just no localized signs of active arthritis.
And before we completely lock into our final category, let's briefly touch on the other severe extra-articular causes of limited opening Odell's text highlights.
The ones you must be vigilant for on the clinic floor.
Yeah, things like acute dental infections, severe pericoronitis from a wisdom tooth, tetanus or scarring and fibrosis.
We can safely discard all of those based on the negative findings in her examination. She has no fever, no facial swelling, no mucosal scarring.
If she had a deep fascial space infection originating from a lower molar, We would see systemic signs of infection and extraoral swelling long before her lateral movements became unilaterally restricted to a single millimeter.
The clinical picture remains laser-focused on a mechanical intra-articular block.
Which brings us to the final category in the RDC framework, internal derangement. Here's where it gets really interesting.
This is the actual structural mystery inside the capsule.
We have a patient who experienced sporadic, painless clicks in her right jaw for years before this sudden lock. Let's demystify the clicking.
Okay, let's break down reciprocal clicks.
I always visualize reciprocal clicking like the condyle trying to roll forward over a speed bump that keeps sliding away.
Yeah.
Is that structurally what is happening?
That analogy captures the mechanics well, but let's add the articular disc into that picture.
Okay.
The speed bump in your scenario is the intra-articular disc. It's a dense, fibrous cushion that sits between the condylar head and the glenoid fossa.
In a healthy TMJ, that disc acts like a protective hat sitting on top of the condyle. As the condyle translates forward down the eminence, the disc slides right along with it.
But in a state of internal derangement, the disc fails to move in a coordinated manner with the condyle.
Usually due to stretched or damaged collateral ligaments, right?
Yes. The disc slips anteriorly, meaning it sits too far forward in the joint space when the mouth is closed.
And this is where her hypermobility becomes the smoking gun.
Exactly.
Generalized joint hypermobility means her collagen is likely more elastic. The retrodiscal tissue and the ligaments that tether that disc are just too loose.
That inherent laxity allowed the superior belly of her lateral pterygoid muscle to constantly pull the disc slightly forward out of its ideal position.
So back in her gymnastics days, when she opened her mouth, the condyle would rotate, then begin to translate forward.
But instead of the disc moving with it, the condyle suddenly crashes into the back band of that displaced disc.
And then it pops over it to reseat itself onto the center of the cushion.
That sudden popping of the condyle onto the displaced disc is the opening click. It essentially recaptures the disc.
And what about the closing click?
As she closes her mouth, the condyle slides backward into the fossa. But because those tethering ligaments are lax, they don't hold on to the disc,
So the condyle eventually slips off the back of the disc.
leaving the discs sitting anteriorly again. That slip is the closing click.
One pop on the way out as it mounts the disc, one pop on the way back in as it falls off. This is the classic cycle of reciprocal clicking.
And crucially, that cycle was painless for years because the nerves and blood vessels behind the disc weren't being severely compressed.
And the disc itself doesn't have nerves in its central load-bearing area.
Right. But then we hit the climax of the case, the chewy meat.
She bit down hard, felt the sharp pain, and her jaw locked at 23 millimeters. What physically broke down in that moment?
The internal derangement progressed into what we call a closed lock. The disc, which was already unstable, finally slipped so far anteriorly that it could no longer be recaptured.
It just bunched up in front of the translating condyle and stayed there.
Exactly. It turned into a physical, fibrous doorstop wedged in the upper joint space.
The sudden locking implies a total obstruction of forward condylar movement.
And this perfectly synthesizes all of our clinical measurements.
Let's run through them again. She can open 23 millimeters because the lower joint space is clear. The condyle can still rotate like a hinge.
She can move her jaw 8 millimeters to the right because her left condyle is completely healthy. It translates down its eminence perfectly to push the jaw rightward.
But when you ask her to move her jaw to the left, requiring that right condyle to translate forward, it hits that bunched up disc immediately.
It only manages 1 millimeter of movement before it is physically blocked by the doorstop.
Furthermore, when she tries to open as wide as she can, the healthy left condyle translates forward, but the blocked right condyle stays put.
This asymmetric movement forces the midline of her jaw to swing toward the stuck side, creating that right-sided deviation on opening.
It's amazing how the transition from years of painless clicking to a sudden, painful, closed lock is just the textbook presentation of this condition.
It truly emphasizes why a thorough medical history and precise clinical measurements are the absolute bedrock of diagnostics.
Oh, absolutely.
And if you were managing this case in practice and needed to confirm the exact position of the displaced disc, the text notes that lower joint space arthrography could be utilized.
That's why they use radiography with a contrast medium, right?
Yes, to visualize the extent of the derangement, though MRI is commonly used today as well.
Okay, let's synthesize the crucial takeaway for the listener preparing for an OSCE station. If you get a Trismus case, You cannot just look at the limited mouth opening.
No, you absolutely must measure lateral excursions.
That is the definitive branch in your diagnostic tree. It separates intra-articular structural blocks from extra-articular spasms or infections.
It dictates your entire management strategy.
Before we go, consider this. We spent today focused on what happens when the joint itself is the mechanical culprit. But what if the scenario was flipped?
Okay, what do you mean?
Imagine a patient presents with sudden painful trismus, but their lateral movements are perfectly normal.
So the string is pulled tight, but the joint translates fine.
Right, and they have no history of clicking. If the RDC system points us completely away from the joint itself, how quickly would you pivot your examination to look for a hidden, deep space odontogenic infection?
Wow, like an abscess from a non-vital tooth or severe pericoronitis.
Exactly. In that scenario, missing the extra-articular signs could lead to a life-threatening systemic infection rather than just a mechanical lock.
That is a very sobering thought. It completely shifts your triage from a joint manipulation to a potential emergency.
And that is exactly why we rely on systems, not assumptions. You have to know where to look next when the clinical evidence points away from the obvious. For more dental examination prep tips and clinical deep dives, please subscribe our Spotify and YouTube channel and share this episode. Keep your diagnostic vision clear, and we'll catch you next time.